This is Yeah, We're Going There with Dr. Natalie, breaking the silence on pelvic health for women and men. Yeah, we're going there because knowledge drives better health. Hey everyone, welcome to Yeah, We're Going There with Dr. Natalie. Pelvic health isn't just an adult issue. Kids can struggle too, and many families don't even realize help is available. In this episode, I sit down with a pediatric pelvic physical therapist to break down what pediatric pelvic health really is, why it matters, and how it can impact your child's daily life. We talk about common concerns like constipation, accidents, bedwetting, and pelvic pain, and how these issues are often misunderstood or overlooked. You'll learn what signs to watch for, when it might be time to seek support, and how pelvic floor therapy can help children feel more comfortable, confident, and in control of their bodies. If you're a parent who's ever wondered, is this normal? This conversation will give you clarity, reassurance, and practical next steps. Today, I'm joined by Sarah Pizzey, a pelvic health physical therapist with a unique specialization in both pediatric and postpartum care. Sarah has been a physical therapist since 2011 and began her journey in orthopedics before discovering her passion for pelvic health in 2014. Since then, she's become one of the few providers in the Los Angeles area specializing in pediatric pelvic health, helping children and families navigate challenges like constipation, bedwetting, and bowel dysfunction. In addition to her work with kids, Sarah also supports postpartum individuals and is a certified lactation education counselor. She recently earned her pelvic rehabilitation practitioner certification, recognizing her advanced expertise in the field. Sarah brings a whole body, deeply thoughtful approach to her work, helping patients connect the dots between symptoms and root causes. Today, she's here to help us better understand what pediatric pelvic health really looks like and why it matters. So, Sarah, welcome. We love having you here.
Glad to be here. Thank you so much.
And just to let everyone know, Sarah and I worked together many years ago in a pelvic health clinic where I treated mainly pelvic health for women, adult women, and Sarah was treating the pediatric or the children who needed to come in or were referred. To this day, though, I continue to refer or recommend her to all that pediatric population. So glad you're here, and going to start to ask you some questions. For example, what exactly is pediatric pelvic therapy, and how is it different from adult pelvic therapy?
All right. So pelvic health is going to be basically regarding bowel and bladder function and other intimate concerns of the pelvis. So children, they have bowel and they have bladder as well. So they can have issues just like adults do. And so often with these kiddos, it might be a lack of a skill they never developed, unlike adults, where it might be that they've developed the skill, they've lost it based on an injury, aging, an illness, or something that's gone on. But for some of these kids, they never really developed the skill. Maybe they didn't get completely potty trained, or they had poor bowel habits or mechanics, even stemming back to being an infant. And so in pediatric pelvic health, sometimes we're trying to help facilitate and really draw out those skills that they need to learn to have good bowel and bladder habits as they get older. So it's the reasons they might come in or the reasons that they are having a problem might be different, but we're still going to be dealing a lot with continence issues of losing control of bowel or bladder function. Pelvic pain might be a case. It might be after surgery of some kind. I know we'll elaborate a little bit more on it in the future part of our conversation, but the examination and the treatments might look a little differently, but the main thing being that we have to be kid friendly. So we have to do things they're comfortable with, but also make it something that is going to help engage them. And so hopefully they come away with learning something and also still wanting to come back and see me.
Love that. That makes a lot of sense. And what led you to specialize in this field?
Yeah. I originally starting out in orthopedics, I didn't really think much of pelvic health. I was working for a clinic where somebody did provide pelvic health. And I started seeing all of her patients coming out just being so happy and grateful for all the work that she did for them. And that's when I started thinking, okay, maybe I'm interested in this. And then I got pregnant with my first son. So that's when I said, okay, I need to know. And so I started pelvic health. And shortly after I really started pelvic health, I also moved to a clinic where I was treating both adults and I was treating general pediatrics and so not necessarily pelvic, but that's when I started thinking, well, I do like working with kids and I do like pelvic health. And so it ended up being even one of the first pelvic health courses I ended up taking was the pediatric pelvic health course. And I'm so glad I did. It taught me, I think it made me even a better um, adult pelvic therapist. I've learned a lot from it.
That's amazing. That was one course I was never interested in.
That's okay.
Yeah, it's working
Yeah,
with kids is
it's
not always
special.
easy, but I do totally recognize what you said about the appreciation
Hmm.
that pelvic health therapists get
Hmm.
as compared to, let's say, an orthopedic pelvic therapist, or sorry, an orthopedic therapist.
Hmm.
Um, Especially, it's a topic that people don't talk about. People
Hmm.
suffer in silence, and when you could help them, it's life changing. So I totally agree with you on that. So my question would be, or to educate the parents out there, at what point would a parent consider bringing a child to a pelvic health physical therapist?
Yeah. I think the most basic answer is when it's really impacting the child's life. And I mean, that could be from a health reason, but it can also be from um, a a social reason, an emotional reason. It can just be what's the quality of their life and how is this impacting it? Is it something other children are noticing? And so that's impacting their ability to make friends. But it can also be from the health reason, such as reoccurring urinary tract infections, often seen in especially young girls. So when you start to notice that something seems off and it really seems to be impacting the development or the even the happiness of your child, it's it's fine to start asking the questions. And you're naturally going to start asking the pediatrician first. And hopefully they have some insight. But if they're under the age of 5 and it's regarding bowel or bladder leakage or incontinence, then it might be passed off as being normal, which is like typically age 5 is really when we want to say that a child can be fully continent. And that includes for the nighttime too. So obviously if it's after age 5, then it might be more obvious that they would come see me. But there are times that even under the age 5 need to come see me because they're suffering from pain as a result, something like the reoccurring urinary tract infections. And I do get some children that just come in because they're having trouble potty training. And they may have already seen some of the potty training experts in their community. But their parents, and it's often because the parent or maybe the grandparent had been in pelvic therapy and they happen to ask the therapist, hey, do you have any pointers? We're having trouble with our kiddos' bladder habits. And then that might stem a conversation of actually, you know that there are pelvic health therapists that do specialize in pediatrics. And why don't we give them a call or why don't we refer to them and help enlighten them a little bit?
Do you find that a lot of these referrals or patients are referring themselves, or versus, let's say, a pediatrician recommending it? Like, do
Yeah.
pediatricians know we exist?
Yeah, that's a great question. I'm gonna say it's probably in my experience, it's been about 50-50 that I because of an adult's perception or experience in pelvic health, that it often will stem, or sometimes parents are at a loss and they're just hearing the same answers of they'll grow out of it. And so the parents starting to Google, and there it might be something that does pop up, whether it's a provider or it's a protocol that recommends therapy as part of it. They might learn about it from there. But I do know of several doctors, physicians who will also refer, but I think it really depends on their experience level with it before that, because there's not many of us out there. A lot of providers don't know it exists,
Right.
or they've heard of it, but they just don't know how to even send. So a lot of it is that they need to know that we exist. And
Yeah.
sometimes it's parents who teach them, teach the doctor that we exist.
Hey, whatever works. And what are like typical diagnoses that pelvic patients, pediatric pelvic patients
Yeah.
present with?
Yeah. I would say the three main big topics are going to be bowel related concerns like constipation, fecal incontinence, and that can range from full fecal incontinence, large stool loss, or it could be encopresis, where there's just more of like a seeping or a smearing of stool into the child's undergarment. Then you're going to have bladder related concerns. Also, a lot of them stemming from leakage remaining or leakage type concerns, whether it's daytime leakage, bedwetting.
And this is all after the age of 5.
Yes, but it might depend on those diagnoses. If the child is having trouble emptying their bladder and they are 3 or 4, it might be appropriate for them to come to me. Or if they're suffering from a lot of constipation, which might stem into uh, n- um, abdominal pain. And so that's another big topic, is the pain subsection. So those patients might come to see me earlier because of abdominal pain, reoccurring UTIs, or pain conditions surrounding that.
Okay. And obviously, kids are different than adults.
Yeah.
How do you educate or explain to the kid
Mhm.
why they're there, what you're doing?
Yeah. Yeah.
What's a typical visit look like when they come in?
Yeah. So the first visit is a lot of getting the history from the parent, depending on how willing the child is to talk to me. It might be I might ask them what their perception of why they're here, and do they know why they're here, and is there anything they know that they want me to help with? And so some kids are shy and some are willing to talk about it. So a lot of it's just the history gathering. But then before I start to do a lot of the examination, which can be a bit more intimate, that might not even happen on the first visit. I am going to educate the child and probably the parent a bit too on bowel function or bladder function, really depending on what they're coming in for. And we'll try to then draw in a play activity to help make it something more interesting and more physical, because I know that if somebody just talks to me too long, I might start to tune them out. And so I can't expect a 5-year-old child to sit still and listen to me talk about human
So, what tools
anatomy.
do you use?
So I have a really good illustrated anatomy book that I got in the pediatric section of Barnes and Noble. And so I'll use that for visual. I'll use my pelvic model if parents are okay with it. To all us pelvic PTs, we have our plastic pelvis that shows all the muscles. And so I'll usually show them that so they have something tangible. And I love it when I get the kids saying, "What's that? What's that? What's that?" So it's really exciting. And then I will draw in a play activity. And so for a lot of the kids, it's understanding how our rectum or our bladder fill and then how they empty. And so it's usually involving, I have Orbeez, or the little water beads that are those slimy little jello-like beads that aren't for food, but kids love to play with them. Or maybe I'll use marbles if they don't want to touch this, like the wet, slimy beads. And then I have a little silicone popsicle mold that I will hold up and I'll kind of hold closed at the end. And we'll just drop the water beads in and say, okay, this is our bladder filling, or this is our rectum filling up. And it's full now. That's going to send a signal to our brain that says it's time to go to the bathroom. And then we'll open the bottom of this little mold up. And it requires me to kind of like hold it a certain way, and all the water beads fall out. And so it helps them understand like that the muscles will stay closed when we're filling, but then as soon as we're over the toilet, we have to make sure those muscles open up, and
I
that
love
will
it.
allow it to come out. And so that's just the basic way to get them to understand about muscles and about like holding in and letting go.
So
And
creative. I
yeah,
love it.
thank you. It's fun.
Do you find that there's ever symptoms that had been dismissed that shouldn't have been dismissed? Like either
Yeah.
by the parent or the physician?
Yeah.
What symptoms should they be kind of not ignoring?
I, I think any type of urinary or bowel loss after the age of 5 is really starting to warrant a critical eye on why is this happening. I think that it's a very common response for parents to hear that the child will grow out of it. And that is true. There are cases of things like bedwetting where, yes, there is a certain proportion of children who it just develops slower for. And so every year of age, that a percentage of children that are still having bedwetting issues is going to start getting smaller. But because there is data on that, a lot of families are told they're just going to have to grow out of it. They're just late bloomers. But because we know in our field, and I think it's just really becoming more common knowledge in the medical world that there are other things that can cause these things. So is it worth waiting and just waiting and waiting, or is it worth addressing it now? Because what are those consequences? Is that child not going to be able to go to a sleepover? Are they not going to want to play their sport because they're leaking poop in their underwear? And so it's something that really you have to think about, like what's the emotional impact, the social emotional impact on these children and their development if we let these problems go on for too long. So it really is something that hopefully we educate on, and it doesn't get dismissed now, knowing that there are people like me out there
Yeah.
who can at least start to help. Hopefully the doctors are going to start doing their testing after a certain point, like various tests to make sure that there's nothing really medically wrong with the child. It's when everything comes back clear that it still warrants seeing somebody like me so we can really put a magnifying glass to the problem and start looking
Yeah.
outside of the box.
Do you find that these issues are more or ever behavioral versus just a physical issue?
I don't think I have ever honestly thought that the issue was behavioral when with all the kids that I've worked with, that I don't think that is a I think it's a common thing that people say, but it's really hard to just empty your bladder or bowel when you don't want to per se. I mean, obviously there's that time when the child's really learning not to do it in their undergarment, and then they're doing it in a toilet, but I don't think that anybody really wants to. It's messy, and obviously it distresses people.
Mhm.
And so I don't think that that's something that really drives it in any of the kids that I've seen. I'm sure it's happened before, but I think most of the time it's behavior that might be driven by something else, and it might actually be the bowel or bladder problem. Maybe they're embarrassed about it, or they don't understand it, or it's causing discomfort and they're uncomfortable. So they're having behavioral problems because they're uncomfortable. So I think it's unfortunately it gets passed off as behavioral a lot. I don't think it always is, but it is a common thing for some kids to end up seeing a therapist or psychologist before they end up seeing me.
Right.
And and I mean, it really depends on what has led the family down that path first, is have they see me or mental health therapy first.
And what about kids who have neurodevelopmental issues?
Yeah, yeah,
Do you see that they're affected more so than, let's say, neurotypical
yeah.
kids?
Yeah.
And do you treat them differently or it's the same?
It often requires a bit of different treatment, but yes, it definitely can be more common in children who are neurodivergent, and a lot of it is because they don't have the same sensory system as we
Mhm.
do, or as somebody that's typically developing does. So there's a lot of sensory components that go into it and sensory integration that goes into it into having normal bowel habits. And so you have to be able to experience that. And one thing that's kind of a term that I don't know how old the term is, but I feel like I didn't learn it in school and I don't know how many other practitioners do, is something called interoception. And so
Mhm.
interoception is that awareness of our body's sensations. And so that awareness of, do we have to pee? Do we have to poop? But it also is, am I hungry? Is my heart racing? Like it's the things that our body is trying to tell us something is going on. And so it's those kiddos that are more neurodivergent that might struggle with interpreting those signals. And so that's another big component of what we have to do in therapy.
And is internal work ever involved with kids?
Yeah, it's a good question. It's very, very uncommon. It's not completely out of the question, but it is definitely not something that is common practice. And it might depend on the provider. Often the pelvic health therapists, we're physical therapists and we're occupational therapists. We overlap a lot when it comes to pediatric pelvic health. And so it might depend on the providers, their credentials. It might depend on their state that they live in or the country they live on, if that's allowed. But it is something that is not used first. Like
Yeah.
it's very common in adult pelvic physical therapy to consider a internal examination. But for children, it's typically more observational. And so I might still ask to look at the perineal area just so I can see what the child is capable of doing. If I
Like
say,
movement.
yeah, if I say, okay, you feel like you're going to fart, how would you hold it in? Or you want to fart, how would you let it out? Or show me your poop strategy. Like, I
I bet
want
the boys love it. We're talking about poop.
yes, well, that is kind of the fun or funny thing that I get to tell them, we get to talk about poop and pee in here as much as we want. And so a lot of kids think that's funny
Right.
and they think it's fun, but when it comes to the examination, it ultimately depends on the individual and the adults involved. There are cases where the family is not comfortable with any kind of visualization of the perineum. That is fine. Sometimes the parent is fine with it, but the child says no. And if
Hmm.
the child says no, we're not going to do it. And so I want the patients to and the families to want to come back and see me because there's a lot of things that I want to teach them. And so I don't want to make them uncomfortable. And so it is really dependent on them. And so that's where we might use sometimes the child will say, I'll let my mom or dad look, but I don't want you to look. So I'll ask the parent and say, what are you seeing?
Right.
And we do the best we can there. But that's also one reason that I started using ultrasound is that there's rehabilitative ultrasound imaging and I can look via ultrasound through the lower abdomen and I can see the pelvic floor moving primarily at the bladder.
So you
And
could
yeah.
basically assess their ability to do the movements
Mhm.
by putting the sound head over the
Yeah.
abdomen so they're not
Mhm.
undressing or put in an uncomfortable position,
Yeah.
which
So
is
it's
great.
helpful. Yeah.
Yeah. I wish all clinics had that ability.
Yes. Yes.
Is there anything that parents can start doing at home to support their kids' pelvic health?
Yeah. This is this is one thing I'm really passionate about is a lot of the things that kids are coming in to see me for, it is not a quick fix. And it's pretty rare that I will see a child for a handful of visits and then they're fine. A lot of these problems might have stemmed for a long time. And so really I want it to come down to prevention, but just how we're educating our kids about their bodies. And so I think it's pretty evident that a lot of parents will teach their kids, you need to eat your vegetables, you need to drink some water, you need to brush your teeth every day. But after a child is potty trained, it's we don't have to talk about that anymore. And so one of the things that I really would love to see and make sure that parents are still talking about with their kids is that we should be pooping and we should be peeing, and what is normal, and even I'm sorry to say, but even looking like that is such a good health assessment, is just looking at what's in the toilet. It will tell you if you're dehydrated. It's going to tell you if maybe you're a bit constipated, and so I think the more we normalize looking, then more that kids are going to be grow up being aware of it, and it's not going to be a stigma of this is gross, we don't talk about this. And so just try to normalize it with whatever words and ways that you find is appropriate as a parent, but really like trying to get the child to want
I love that.
to do, yeah. And I obviously it's going to depend on the age of the child, but even when children are potty trained, still go in and look and keep track of how often they're going, especially in the first year or so, is that now, yeah, they're fully capable of identifying when they need to go and to get there. But how often is it happening? Are parents aware of this? And it's hard when they're school age and then they disappear for half the day. But if you set those skills earlier, then they're going to be able to also be able to identify. The child might remember, oh yeah, I remember pooping at school, or I went to the pee twice, and so they can give feedback and they're going to start to remember that more. So try to make it normal to talk about it.
So, in adults, like one of the pieces of my education is not to go to the bathroom, like just in case before they leave the house or before they
Mhm.
leave work. But growing up, I was always told, go to
Yep.
the bathroom before we leave. And
Mhm.
I'm sure all parents still do that.
Yeah.
Is that a bad thing? Is that like training them incorrectly from a young age?
That's a great question, and I my perspective is really that they more ask, "Do you need to go?" is probably the better question. And this goes into that interoception, into that awareness of what your body's telling you. Like if I sit here and I think about it, I can tell myself, "Yeah, there's probably a little urine in my bladder." If I was about to get in the car to go for a 6-hour drive, I probably would say, "Yes, I'm going to go because I'm about to drive really far." Or if I'm about to go into a 3-hour movie or something. But you want the kids to really develop that sensation, and so you gotta do that early. You don't wanna wait until they're too old because everything changes. You want it to be a skill they learn early on, so talking about what it feels like to you, and the words that we use don't matter, because what the way I might describe a sensation might be different than the way a child or even another adult might describe it, and that's fine, but it's what it makes sense to them. So if it feels like there are bees in my bladder, bees is probably not the right word. Maybe like little flies, like something's tickling the inside of my bladder. Like that's perfectly fine to use like that kind of analogy. It's what's valuable to them. So really helping them to feel that from an early age is a better skill. But just like with the adults that we treat, we have to help them understand, yeah, you don't want to just in case all the time, but there are going to be those circumstances where you're going for a long car ride or there's not going to be a bathroom available. And so naturally, if there's urine there, you might go empty it. But understanding, well, when was the last time I went? If I only went a half an hour ago and I'm only going to be gone an hour, like, no, it does not warrant going to the bathroom in that amount of time if you know your habits. And
Right.
so if parents start to identify what their child's habits are, if they can keep track of that, or if the child's old enough to keep track of that, that's when you can help them understand some of that calculation we have to do. Okay, should I use the bathroom, or is it okay not to? And so that's a skill that I think needs to develop more and more.
Yeah. No, I think you explained it really well. And what about the kids who are chronically constipated? Do you recommend a squatty potty? Do you talk to them about fluid intake and fiber and all that?
Oh, yeah. Yeah, we do all of that, and depending on the age of the child, it might be more of a
Parent.
parent type of a conversation, but I think it's still important to have those conversations about fluid intake, especially if the child's at school, like, "How much of your water bottle did you drink today?" And so that way, we can start to it might require the diary type of a situation, like, let's track what somebody's doing day to day, and then we can all look at it together and decide, is that something that needs to change or not? But I do one of the first things I usually teach the kiddos is toileting posture, and that's for whether or not they're here because of peeing, pooping, or pain, is that some kids are still too short for a traditional toilet. And as you and I both know, and anybody who's probably been to pelvic therapy knows, is that a toilet is not a optimal position for us to be. Like, a sitting position is not optimal. It's more of a squatting type position. And so we need to get something under our feet, especially for bowel movements. And so I will pull out that, usually visit one or two, and I'll have the child sit on it, and then we talk about what's even normal from there, because simply getting your feet up on one of these things is not enough. We've gotta get the pelvis in the right position. So most of the kids I see, they get to learn happy dog. So when you want your tail out behind you, you don't want your tail tucked underneath you. So if you're sitting on the toilet and you're slouching, your tail's gonna feel a bit tucked. But if you are a happy dog, you want your tail out behind you. So you want to tilt the pelvis and to help get that tail out behind you. So I think it just helps to give a name and a visual to the child, because it's difficult to even teach an adult how to tilt their pelvis. But once you start to use those kinds of words and analogies, they start to pick up on it. So pretty much every kid that comes to see me knows what "show me your happy dog" posture, and
And
so
that's for toileting.
yeah, for sitting on the toilet, and with the squatty potty is that you wanna be the happy dog.
And arms are resting
Yes.
forward as you're in that position.
Yep, 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 same
And
position.
fluid intake, do you ever discuss that? Because what is
Yeah.
normal fluid intake for kids?
Yeah, so it's gonna change depending on the child's, age, and even, like, with adults, the value might change depending on their activity level or other circumstances, but, I usually use the, American Academy of Pediatrics recommendation for that. So 1 to 3 years old is generally about 32 ounces. 4 to 8 years old is about 40 ounces, and 9 or above is 56 to 64. And usually by age 12, we kind of start to say you're pretty much at an adult level, or more adult norms. And so then you're going to go to more of those values. And so, but that doesn't always have to be. Most parents might say, you want my 3-year-old to drink 32 ounces? Like, it doesn't have to be that that's how much, like, straight water they're drinking, but you
Right.
have to think, what else are they ingesting? Is the food they're eating full of fluid or water? Are they having soup? Did they have a popsicle?
Mhm.
Are they having steamed vegetables? I mean, things that are going to have fluid content too. So it might not be 100% of that straight water, but how they're going to get it in. And you have to break it up. So we talk a lot about, like, breaking it up into reasonable amounts and not allowing it to be this daunting, okay, child, I want you to drink this entire thing right now. Even adults aren't going to want to do that. Make it achievable for them.
Right. And I know for adults, a lot of my patients, their doctors recommend Miralax and
Mhm.
Benefiber. Do kids do the same thing? Just obviously different amounts? Is
Yeah,
it safe
yeah.
for kids?
Yeah, so when it comes to Miralax, it's really commonly used, and so it's considered safe for children. I think there are people out there who will disagree with that, but it is one of the standard practices, is whether it's a pediatrician, a pediatric gastroenterologist, even pediatric urologist, they might be prescribing Miralax to help get bowel movements going. And so it's really commonly used, and some kids will end up on it for years
Yeah,
because
my
they
sister-in-law in Canada is a pediatrician,
Uh-huh, yeah,
and
yeah,
Miralax is a staple.
it is, and so, um, it can be a common thing for kids to end up on, but there should be other things going on to help move that needle forward and allow that child to eventually wean off of that. We don't wanna see that as something that
Long
they
term.
indefinitely are gonna be on, so that's where therapy comes in. And that's where understanding that the one thing that I really try to instill in my families is if you're told to use Miralax, that is fine, but ask about how do I know it's working the way we want it to? Because a child, this is one thing that a lot of people might not understand, is a child might still go to the bathroom every day, not strain. And it looks like what we consider that perfect type 3 or 4 on the Bristol stool scale, or just that kind of smooth log or sausage looking appearance, but they can still be constipated.
Mhm.
And so, if there are problems going on, then we have to look deeper. It might be that the child really needs to get an X-ray to really see what is the stool burden in their abdomen. And so if there are those signs that something is going on, then I wouldn't just say, let's just take Miralax. I'd say, okay, let's start with Miralax. We might do a Miralax clean out, and it might be part of the plan. And it might even be still a long-term plan, but we have to be figuring out, like, what is that long-term plan to get them
Right, and
of
if
it.
there's no changes, you need to do more
Yeah,
research.
yeah, yeah, and there's lots of reasons behind it, that some things I can help with, but some things I can't, and so it's about really seeing the experts to understand what are some of the other things we need to be looking at as well.
And in kids, I know obviously there's a lot of bedwetting, but daily leakage, is that pretty common with kids?
During the
And do you
day.
yeah, and do you teach them
Yeah,
Kegels? Like, how do you teach a kid a Kegel?
I know, right? So it's daytime. I do get a fair amount of kids that do get some daytime leakage. And sometimes it might not even be why they came in to see me. Maybe it was a constipation issue. But then when we further look at it, it turns out, oh, yeah, they actually are leaking some urine too. And so the daytime is something that we do have to look at. If a child's, well, pretty much any child that comes in for a bowel issue, a bladder issue, a pain issue, I'm going to dig deep into bowel habits. Even if child and parents say, no, 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 they're not constipated, you're constipated until proven innocent. And so, because it can even look like apparently normal, but still be very backed up. So, a child that comes in with a urinary leakage issue, it could be driven by constipation. It could be that the rectum gets so full that it is triggering the bladder to empty. It could be irritating the nerves going to the bladder, because the nerves that are coming from the spinal cord to go to the bladder, they have to go around the rectum. Well, if the rectum is getting really, really full, that's going to start irritating those bladder nerves. So that's when the leakage might actually be caused by constipation, whether we know it or not. And so that's a big thing that we start with when it comes to that daytime concern, or the nighttime as well. But when it comes to teaching a child how to do Kegels, yes, we do work on it if they have been okay with me looking. If the parent, the child are okay with that visual examination, then I will usually add a mirror. And because at this point we've already talked about that we need to fill our bladder valve, we need to empty it. And so they're starting to understand that they have muscles that help them control that. And so then if we add a mirror and I say, okay, so let's look, and it's usually easiest to just look at the anus because it's very obvious what's happening there, and say, okay, show me, can you close it? Can you make it smaller? Just lots of various terms. I might use a Q-tip to just point to it, not necessarily touch, but just point and say, right there, can you make that small? And or can you act like you're trying to hold a fart in? And if they see that, then that's really valuable because once they see that and they feel it and they will start to learn how to do that.
They're
And
making the
so
connection
yeah.
between
So
the 2.
exactly. They're starting to make that connection. And when a lot of the kids that come to me, especially if they were referred by a pediatric gastroenterologist, they're often sent for biofeedback. And so in the most traditional way for adults and children is going to be like 3 small little sensors that are just little stickers that go on the outside of the bottom, and they have wires that go to a computer that show a graph of when somebody's contracting, the graph goes up, or relaxing, the graph goes down. And so a lot of kids end up getting sent for that because it's helping them with that visualization. It's helping giving them a feedback of something's happening. So depending on the equipment you have, sometimes it's more video game like than others. And so that can also be another way to engage a child to help learn how to coordinate these muscles and to understand that concept of what squeezing feels like, what relaxing feels like, and then having the child identify, when do we want to be squeezing? When do we want to be relaxing? And also teaching them how to bear down for a bowel movement too. So just like with my adult patients, it's a lot about coordination
Yeah.
versus a certain strength. And so I'm not strength testing children. It's more like, do they have control or do they not? And what can I do to help facilitate that?
Right. Okay, great. And what would you recommend, like, how should parents talk to their kids so as not to, like, shame them into,
Yeah. Yeah.
not wanting to get help?
Yeah, it's a good question. It really stems from what words were used when they were really young, when they were potty training, but even pre-potty training. That if when they're changing their diaper, what words can you use to help them understand what is in their diaper? And did you feel anything before you pooped in the diaper? And so I think starting that really early is really important. But for the kiddos who are older kiddos and they're starting to have these problems or these problems are more evident, it's important to make them understand that this problem is not their fault
Right.
and that they likely couldn't control it. And I think that the word that's tossed around a lot is accident. And I don't know the actual dictionary definition of accident, but some practitioners will say that an accident might imply that they had some control over it. It might have just been poor judgment, but in a lot of these cases, the child might not even be aware that they had to go or that they have gone. And so when parents respond, and often it's out of they might be frustrated, and so it's really important to try not to overreact to it. I know it's hard because how inconvenient is it when it happens in public and you don't have a change of clothing, but trying to stay calm and try to really lead with love and make sure that they're okay and they're safe. And then how are we going to address this? And so not shaming. I mean, it really, a lot of these kids don't feel it. If your rectum has been stretched out for so long because of longstanding constipation, you're going to stop realizing that anything's there. And
Right.
then that might feed over to the bladder, that the bladder is just so used to getting pushed on by its neighbor for so long that it starts to kind of filter out that white noise. There's certain things about our sensory system that we can filter out because we've just learned that it's not important information. And so that's happened with a lot of these kids, or they really just don't have sensation. So when parents respond with, "Well, why didn't you tell me you needed to go to the bathroom?" They might not have known. And so it's about saying, I wonder why that happens. And then start to talk with them and like, let's investigate this. And why might this have happened? When was the last time we went to the bathroom? And what does it usually feel like to you when you need to go pee? So that way we're starting to help them understand how to identify that these problems are here. So that way they can start trying to learn what these things feel like. And those more subtle things that they've tuned out will hopefully start to come to the surface more and help the child identify it. So our words are really, really important. So it's just really important to understand their understanding and in their developmental age, and do they have the tools necessary for proper continence, and go from there.
So, do you ever teach like timed voiding
Yeah.
to help? So, what that is where they go pee at a specific time during the day.
Yeah.
When a parent needs to have their child do that, how do they advocate for that at school?
That's a great question. And it is really important that there is support at school. Maybe the school doesn't need to know all the details of why, but even the parent just making it clear that my child needs access to a bathroom, and they need to go when they need to go. It might depend on the school and what things they have in place. That there are some families that come back and they say, our teacher's great, our school is great. If we say they need to use the bathroom when they need to use it, they're going to let them go, or that they've already told us that all kids get access all the time. There's no problems. And then you're going to have the ones who the teachers will say, but you just came back from lunch. I don't think you really need to go, or why didn't you go at lunch? You're not going to be able to do this next time. And then you're going to have the ones that are saying, nope, nobody can go, which hopefully that's changing, but these children need access. So it's really
Mhm.
important that they're given access. And so whether it is just a simple conversation with the teacher or school, or whether it needs to be escalated into writing, and whether it's a doctor's note or the parent has to apply for a 504 program, or if it needs to be integrated into an IEP, if the child has an IEP, that we need to make sure that there's some form of communication and documentation in place, so that way if the child is refused access, that they have that a complaint can be made,
Right.
that they are not given the tools they need to thrive in school. And so it's really important there. But one thing that I will do with kids, because the timed voiding or even the repeated questions of, can I go to the bathroom? Maybe their peers are starting to notice that. And their peers are like, but why do they get to go all the time and I don't? And so it might need to be more discreet. So if yeah, there are watches. Sometimes it could be a watch that just vibrates. And so if the watch vibrates, maybe the child has a certain hand signal with the teacher. And so they can raise their hand and give the hand signal, and their teacher, all they have to do is nod or go and tap them on the shoulder, and that's their, I see you. I hear what you need to do. Go. Some kids, maybe the watch will be too distracting. So maybe talk about the teacher wearing the watch. And if that watch goes off, then they can give them the signal. And that's the signal for the child to go to the bathroom.
Love that. That's so great.
Yeah. So it's about finding the discreet ways. But I'm finding more and more that teachers are really great, and they're on board for these things, because they don't want the children to have an accident in the
For sure.
classroom, and so they're on board.
What are other typical accommodations that a kid may need or that a parent may need to request for their child?
It might be that they need access to a certain bathroom, that if they're going to be sitting on the toilet for some time, they don't want their peers knowing, like, they're sitting in there, or some kids have a lot of gas when they're
So, like a private
constipated.
bathroom.
And so, yeah, they may get access to either a teacher's bathroom if that's allowed, or most common is the nurse's bathroom, is that they're allowed to go to the nurse's
Got
restroom.
you.
And then another thing that they may have to have is that the nurse has a change of clothes in their office for the child, so that way that if the child does need to change their clothes, that there's something available for them. there. Those are the most common things that are asked. Sometimes it is, and usually in the smaller schools, it's easier, or the preschools is to have the child go sit, because we're often trying to get kids to have their bowel movements after they've eaten, and so that might end up being after lunch, and so some kiddos might need a bit of time at the end of lunch or when they come back from lunch to go sit on the toilet. So those are usually the type of things that we're the accommodations that we need. I've had parents donate squatty potties to their kids' school, which is great. And so it doesn't make it a, oh, my child needs this thing.
Yeah.
It makes it more of a, this is here if they need it. Again, it's usually the smaller kids or like the kindergartners who have their bathroom in their classroom. And so, but if those things are there, then that's really helpful.
No, I love that idea.
Yeah.
Actually, you saw my face light up. I mean, I think every bathroom should have a squatty potty for sure. What if these issues aren't caught or addressed earlier
Mhm.
enough? Like, can there be complications?
I think it just gets harder to treat as it goes on longer, especially anything driven by constipation, that the longer the rectum stays enlarged because of excess stool burden or even the rest of the colon, the more it's going to impact the actual function of those structures. And so and even like the muscle tone. So we have that smooth muscle throughout our colon that is helping to push things through. But just like with a skeletal muscle, like our arm or a leg, if it gets overly stretched, that it's not might not work as well. For so the same goes true for the bowel. And so if it's had a time period where things have gotten a lot more stretched out, then it's going to take longer. And so that's where some of these kids are going to they might end up on a laxative regimen for 6 months or a
Mm.
year, depending on how long it's really gone on. And so that's why I'm passionate about the prevention. Let's prevent it. Um, and so the longer it goes on, the harder it is to treat and the more impactful it's going to be on the child's more emotional and possible social development. And so it really needs to be treated sooner.
And how early is too early to intervene?
I don't really think that it's ever too early to put our Sherlock Holmes hat on and get that magnifying glass out and say, what's going on here? Let's investigate this. We need to be detectives of why is this happening? And it's when you can't answer those questions or you don't have the solutions that you need to be starting to seek help out.
Yeah.
And so, and some families are very intuitive and they have a lot of knowledge that they can start implementing, and then some are going to have no idea and they really need a lot of guidance. So in some coming to therapy with me, that I think of myself like with all pelvic health patients, think of yourself kind of like the coach, like you get to see the whole field and you get to direct all the different players on what needs to change. And so you might be that one that can take that step back and not just look at only the bladder or only the bowel, that you can say, okay, I'm looking at bladder and bowel, but I'm also noticing some sensory concerns, or maybe the child can't even get in a squat position. They don't have the strength or the range of motion to squat, or they don't have the core control to push a bowel movement out, or they're having airway issues. So I like being able to say, okay, but there are also these other areas that we might need to look into. So I think like having that help earlier is better. We don't want to over magnify it and make it uh,
Scary for them.
yeah, exactly. But at least starting to say, "Hmm, is it worth is it worth pursuing some treatment?" And so that's what I love about my job is to be able to help kind of guide families in the directions they need to go in. And yeah, I'm always happy to do them no matter to do that no matter what their age is.
Right. No, I agree. I agree. Prevention, if everyone could learn at a young age good bowel and bladder habits,
Mhm.
we would see a decrease in adults needing
Absolutely.
therapy and
Yeah.
purchasing diapers for adults and all that. So,
Mhm.
yeah, no, I agree with you 100%. Before I wrap up, I do have a question about bedwetting.
Yeah, yeah.
I've read that after the age of 7, it's always a concern. Is that true or false?
Yeah, I typically would put that age at 5,
5.
that if it's happening after 5 and beyond, then I wanna know what could we be doing, and so, yeah.
And what about, like, those I know there's alarms that people could put in the
Mhm.
bed and stuff like that. Do you recommend those? Do you think they work?
I tend to be more along the lines of, "Let's make sure there's nothing else,"
Right,
because if it might help, but if the child ends up being really constipated the whole time and you don't identify that, that either the alarm is gonna be useless, or if it works a little bit, then as soon as you take it away, then the
they're
problem
back.
might still be there. And so I think it's just one of many tools that we can use, but because that's not really teaching you to identify the sensation beforehand. And it's kind of more of an after the fact
Got it.
thing. And it's already happened at that point. So what can we
Right.
do to help predict it? Like there's even I personally have never worked with one. I would love to, but there's something called a go-go band, I think is what it's called, where it actually reads your heart rate variability overnight, and it will send a signal to a phone, which will then prompt somebody to get up and get that kid to go to the bathroom before it happens, because their body's starting to sense that something is going on, that there's a something's changed. And
So the
so
parent wears it or the kid wears
I
it?
think it depends on the age of sorry, the child wears the heart rate variability sensor,
Oh, and the
but
parent
like,
wears
the device that's actually alerting, I'm pretty sure it might just go to a cell phone, because I haven't actually had my hands on one, I don't exactly know, but I think, like, that kind of technology is just really valuable, that it could send a
yeah,
signal to a phone, and so whether it's something a child can respond to or the parent has to respond to, at least it's helping to identify that before it happens. But it's still the question is still, like, did the child actually learn to feel anything? Maybe not, but at least it's helping to prevent the problem before it gets messy.
that's interesting.
So, but you have to clear that bowel first, and you have to investigate other reasons before it's a lot of work, that these kinds of alarms and things. And so I mean it all can be a lot of work, but really identifying the problem. So with bedwetting, in addition to constipation, you have to understand airway. So any kind of airway disruption, it could be snoring, sleep apnea, just disordered breathing, that can be a cause of bedwetting.
Really?
And yeah, so that is, if if you know your child has airway issues, then you need to be talking with the doctors about, do we need to go to the ENT? Would seeing a myofunctional therapist be appropriate for them to get some exercises to help with breathing and airway? And so you have to look at that, but you also have to look at genetics, that there are some kids that you rule everything out, and it might just be genetic. There's a really high incidence of a first degree relative being a bedwetter, that they have a higher chance of being a bedwetter. So whether one of these other problems was also genetic correlation is a question, but there are those kids that you've ruled everything out, and they just end up they have to be on medication if they want to be dry.
Is that medication needed forever?
It shouldn't be, and what should happen is that periodically they do trials of weaning off of it
Got
to
it.
see if it's necessary, and or maybe they have it on hand for a sleepover or something, where maybe they don't take it every night, but they take it when there's times that they really cannot wet the bed. Maybe they still wear a pull-up, but they're at least the medication can help to just stop it if it seems like there's really no obvious problem, or at
Wow.
least the cause is not, if it's not something that can be resolved, then there are medication options that a pediatric urologist can prescribe.
Cool. So if like listeners have a family member where they believe would, be benefited by
Yeah.
going to a pelvic therapist, where do they go to find a qualified pelvic health physical therapist?
Yeah, it can be tricky. I think the best thing that you could do is to contact a general pelvic therapist and then ask them, do they treat, or do you know of somebody who treats in the area who treats this? Some of the major medical centers will have physical therapists, like in their like bowel or motility programs, they will have physical therapists on staff, and so you can contact the major medical center, or ask the, obviously the specialist like a GI or urologist should be able to might be able to answer that, but even they might not know. And the more rural the area, the more difficult it might be. It's not uncommon for these kids to have to travel to us to
And
seek us
what
out.
about like, I'm sure you're listed on it. I know I am, like
Yeah.
pelvicrehab.com.
Yes, yes. So that is a great site. I don't know that there's like a filter to say I'm seeking out pediatric. So it might be down to going to pelvicrehab.com
And
and
calling.
then looking at who's in your area, and yeah, contacting that therapist, or read the profile of each therapist and see
Right.
if anybody says it. And some people won't actually say they do pediatrics, but maybe they do, and whether it's something they
Hopefully they
advertise
do.
or not.
Yeah,
So it's just worth asking the questions, and hopefully more and more of us out there, with more and more pelvic rehab practitioners out there, that more and more pediatric pelvic practitioners will start popping up. And so, yeah, I am passionate about others wanting to get into this as well. And so it's really rewarding
I know.
when it gets down to it.
And I guess one question I probably should have asked at the beginning, what is I guess talking about statistics, like what's the population of pediatric patients needing pelvic therapy?
Oh, well, I think it's a good question, but probably has a lot of gray areas. So I don't know if we would have an exact number on that, but a number that sticks out in my head just to kind of put an understanding of the incidence. Now, the study I'm referring to was a Dutch study, I'm pretty sure. So, and different country, different lifestyles. So
Sure.
it could be very different. But in a group of kids that they looked at to understand the incidence of constipation, I think out of the population of kids they looked at, I think it was 15-16% ended up being constipated based on the criteria that's in the medical society. But when the child was asked about their bowel and bladder habits, I think it was 64% of the children that were actually labeled as constipated did not identify that they had a frequency problem, like how often they were going was a problem for them. So there's a lot of kids out there with these problems that don't know that they have a problem.
Right.
They
So
might
there
not
it comes
know.
back to what you said earlier about the need for constant communication. Doesn't
Yeah.
just stop.
Yeah, it's and communication, or at least giving them the skills to identify what is normal and what can I do about it. That if, gosh, I usually poop after breakfast. I didn't poop after breakfast today. I wonder why that is. And then making sure you think, okay, I'm going to make sure that I poop tomorrow. Because if I don't poop tomorrow, that's probably a problem. And if that's not my normal. And so it's just, I think it's about being able to look inside and to assess your own health. And so that's the tools that we really need to be giving our kids, and to understand what are the basic health needs and what's normal, and then what can we do about it? And that's why I think we need to revamp the high school health class.
Amen. Yeah, I couldn't agree with you more.
Yeah.
I couldn't agree with you more. Well, thank you so, so much for joining me today.
It's a pleasure.
Hugely educational. I thought it was fabulous. And
Thank
I
you.
really believe that people are going to listen to this and make changes in how they communicate with their kids.
Yeah, yeah. That's
And that's the goal. Well, that was awesome. Thank you so much.
oh,
And if people want to be able to reach out to you,
mhm.
is there a way that they can find you?
Yeah, so the company I work for right now is called Movement X, and so if you go to movementx.com, we are across the country, but we are of all specialties of physical therapy. So if you're wanting to seek me and my expertise out, the best way to get a hold of me is to look on the website and go to California, the locations, California, and then I'm the one listed under Long Beach. And so you'll find my profile there. And then there's a phone number there, which I can also give here is 949 and 438 3088. And the website is movement dash X. So there's that little dash in there. But if you just Google Sarah Pizzey Movement X or Sarah Pizzey physical therapy, there is a Sarah Pizzey somewhere. She's a pelvic health therapist, I think in Australia. I
Wow,
saw her name on
it's
like a
not a
Facebook
common
group.
name.
If she hears me, hello. But there's not many of us out there. So, but yeah, hopefully there's help out there. And yeah, I hope to do more things like this. And I want to do a potty training readiness workshop someday. So that
Oh,
to help us learn how to communicate with our kids and teach our kids those skills before they even are
incredible.
using the potty. So look out
Yeah,
for
I
that.
think that's incredible. I think that would be huge.
Yeah.
Well, thank you again. And we'll get you back on when, listeners start having more questions and, you know, questions I can't answer.
That
Definitely
sounds
reach
good.
out.
Absolutely.
Okay. Take care.
Thank you.
Thank you for listening to Yeah, We're Going There with Dr. Natalie. If this conversation helped you feel more informed or less alone, consider subscribing, leaving a review, or sharing the episode. Until next time, yeah, we're going there because knowledge drives better health.